Thank you very much. Thank you, Chairman. I'd like to thank Dr. Sunil Kumar for having me here. I'd like to just go through stents which are being developed nowadays with the complex procedures that we are going through and the kind of stresses we go through for the complexity of the disease that is we are facing. The stents are being developed, and as you see here, from 1977 when POBA actually started, you see that the amount of restenosis, the failure of PTCAs was much higher, and as the time progressed, where we started off with bare metal stents to now to drug-eluting stents, the amount of restenosis has come down, but we still are aiming for perfection. Now, in addition to our expanding knowledge, there is also an increase in the complexity of the disease and also the expansion of the indications for angioplasty, where we started off with much simpler cases, and now with small vessel lesions, and then we have gone on to actually tackle left main disease now. As you see here, as the time has progressed, the complexity of the disease has progressed, and therefore the challenge to improve and improvise on our stents and the other devices that we need. Now, the stents basically are comprised of, regulating stents are comprised of the platform, the polymer and the drug. Now, this is where, these are the three areas where major amount of work is being done to actually change and improvise. Now, coming to the stent design and delivery system, there are new designs being made for small vessels and for bifurcations. The drug carrier vehicle, we are making bioresorbable polymers, and we are making polymer-free stents for the kind of problems polymers are causing. And we are trying to move from anti-proliferative to now pro-healing drugs and drugs that actually increase endothelialization. Now, these are the different solutions for the next generation of drug-eluting stents. There are new coatings available, like absorbable coatings, new biological targets like endothelium, and antithrombotic medication impregnated on the stents, newer drugs like cytostatic and cytotoxic drugs. But the major focus is still on pro-healing approach and the pro-healing with drug-eluting combination approaches. Now, these are the different kinds of materials that are being, the drugs that are being developed. Get into more details. Now, what are the problems we're facing with the present drug-eluting stents for which we need solutions? Is stent thrombosis. More so we are worried now about the late stent thrombosis, which is a problem because of the incomplete endothelialization. In antiplatelet therapy and bleeding is an issue. We're trying to get rid of as much of antiplatelets where we can, because on a long term, when patients require surgeries, we all have nightmares and restenosis as such. Now, the newer stents, we'll go through the categories: the metallic stents with durable polymers, new anti-proliferative agents, new metal platforms, biodegradable polymers, polymer-free stents, biodegradable stents, novel stents, and dedicated bifurcation stents and self-expandable stents. Now, coming to the metallic stents with durable polymers, as an Endeavour Resolute, which has 3 stable polymers, it helps in delaying the drug release, and has been shown to be a very effective drug-coated stent. Probably right now among the drug-coated stents, there are most of these are the most successful drug-eluting stents in terms of the 3 major ones that are available. The new anti-proliferative agents are like the Elixir DS-Sign Novolimus eluting stents, which has the mTOR inhibitor, which the XLR and the XLR2 study is going on. The new metal platforms are the platinum chromium platform with the element stent platform for Taxus and Promus, combined with everolimus in Promus and paclitaxel in Taxus. The advantage here is basically it has a better radiopacity, it has better radial strength, and therefore and also has thinner struts, which helps in it being better deliverable. Now, platinum trial for the Promus element has shown that it is non-inferior to Xience, and Perseus trial for Taxus with Taxus liver. Now, here as we see, these are the things where we have nested peak things, so that the amount of at bends the struts are not in contact too much, and this helps in actually also in side branch cross. Now, coming to the current problems with polymers. Now, the problem with polymers is either there is some problem with a non-uniform polymer coating, or sometimes there is webs formed between the struts, which when expansion there may be problems in cracking, and polymer delamination, which could actually cause stent thrombosis and incomplete endothelialization. The durable coatings actually are a potential for continued inflammation and therefore poor healing and thrombosis risk. Now, tests with biodegradable polymers is developed to address the issue of stent thrombosis and restenosis due to the polymer. The issue with these biodegradable polymers is basically the drug release pharmacokinetics is still not controlled, and therefore the clinical outcomes are still not clear. There's a lot of trials going on. The leaders trial as well has shown that it's non-inferior, but there are issues still. The polymer breakdown may actually cause a lot of significant inflammation, which then creates an acidic environment, which could lead to a lot of restenosis. And the monomer breakdown can also cause persistent immune response. Now, there are a lot of biodegradable polymers stents available now, like the Supralimus, Excel, Biometrics, Nobori stents, the CoStar. Most commonly used here with these are the Biometrics, which has a stainless steel platform with Biolimus A9 polymer, and is only abdominally coated and has strut thickness of only 15 micrometers, and it is biostable polymer and it is athromogenic. It has a poly L lactic acid polymer, which then gets decompensated into it gets degraded into carbon dioxide and water in 9 months. The polymer-free stents, to avoid the problems with polymers, as it has advantages in terms of getting rid of the polymer issues of endothelialization. It also it acts like a bare metal stent after the drug is eluted, and therefore we can avoid dual antiplatelet agents on long term. It improves the healing and also improves the stent integrity because of the absence of the peeling of the polymer. Now, these stents elute by attaching drug directly by covalent bonding or crystallization, impregnating on the porous surface, or dissolving the drug into a non-polymeric biodegradable carrier on the stent surface. It acts as a cobalt chromium, whereas both of the rest are stainless steel ones. Here, as we see, that it's a polymer-free coating. It has a unique roughened surface on which the drug is actually coated, and we have a choice of which drug we actually want to coat as well. Now, coming to the stents with novel coatings, it's the Catania stent which is being developed, which has a cobalt chromium stent with a nano-thin coated polysine polymer. This polysine polymer is basically anti-inflammatory, it's biostatic, has a bacteria-resistant, biocompatible with pro-healing qualities, and the coating also has low thrombogenicity. Now, the Atlanta trial is being done and has shown that these patients actually have used only dual antiplatelets for 30 days, and there was no stent thrombosis as such. Now, the other novel stent is the Titan 2, which has a titanium nitride oxide coating. Now, this coating helps in inhibition of platelet aggregation. This minimizes the fibrin deposition, and it reduces inflammation and therefore promotes the healing. A Titan AMI trial has been shown to be actually favorable and has shown to be better than Taxis Liberté, but the TIDE trial, which was actually compared with Endeavour, did not prove so. Now, coming to the future of DES platforms, the key is basically the endothelium, where we need active support of the endothelial cell proliferation and migration after stent implantation, accelerate the endothelial cell strut coverage, decrease smooth muscle cell activation, and reduce collagen secretion, and therefore help in optimal healing response and accelerate functional endothelium. Now, this is the genus bioengineered R stent, which is a stainless steel bare metal stent, which is coated with antibodies to CD34 coated on the abdominal surface. They bind to the endothelial progenitor cells and help in faster endothelialization, and therefore reduce the potential of stent thrombosis and restenosis. But the stent has been shown to actually have a late lumen loss, and therefore it has been improvised into a combo stent where it has been combined with the sirolimus, which actually inhibits the neointimal proliferation. Now, this is a genus stent where it is coated with a anti-CD34, which actually helps in combining with the endothelial progenitor cells and therefore helps in rapid endothelialization. Now, this is the most interesting and most interesting thing to actually now, which may revolutionize the whole process of stenting, the biodegradable stents. The advantages are basically it reduces the amount of stent thrombosis. There is no need for lifelong dual antiplatelets, which therefore reduces the risk of bleeding. It helps in restoring the vessel vasomotion. As we use the metal, the vessel vasomotion is actually hindered, and whereas here, over a period of the next, after stenting 2 years down the lane, you may not have any stent there, and the vasculature gets back to normal. And the late vessel remodeling is therefore prevented, and future requirements of any PCI or CABG to actually put in a graft there, you can actually use the area as well. Now, current biodegradable polymers are either polymer-based or metal alloys. The polymer is generally polyl lactic acid, which actually is metabolized by the Krebs cycle and is degenerated into carbon dioxide and water, which is then phagocytized by the macrophages in 12 to 18 months. The only issues with this is because there is no metal there, the radiopacity is very low. The radial strength is also very low. In the trial there have been strut fractures in the patients where the stent was implanted, and the struts are slightly thicker and less deformable, so deliverability is an issue. Now the PLLA stents are Igaki stent, which is now being used more for peripheral stenting, because for delivery and delivery the stent you need to heat the stent, and this is being shown to actually cause damage to the endothelium. Whereas the Abbott vascular bioresorbable vascular scaffold, they called it a scaffold and not a stent because there is no metal there. PLLA is the backbone as the scaffold and is coated with PDLLA, and is actually a drug-coated stent with the everolimus. We've been part of the trial and seen good results with this. It elutes almost 80% of the drug in 30 days. We've done around, I think, 15 to 20 cases of this and had no bad experiences as such. It's not radio opaque at all, but there are two metal struts there, metal dots there, which actually help you in positioning the stent. And as we see here, the scaffold is very radiolucent, and as you see in the OCT pictures, initially, if you see the picture A, that is where the stents have been implanted, and over a period of years, the stents, it's all gone there. It's all resorbed and there's no scene. The other biodegradable stents are Riva stent, ideal polysalicylic acid stent, but all these are still at the level of research. Now, the metallic stents, biodegradable metallic stents, are made out of magnesium, 93%. It helps in rapid endothelialization, but it has been shown to actually increase the restenosis, and therefore trials are going on with these stents after drug coating. Now, coming to another issue which we commonly face now is the dedicated bifurcation stents, which the bifurcation, basically the problem we face is, one is the inability to sometimes cover the ostium completely, distortion of the main branch stent after dilatation of the side branch, difficulty in maintaining the side branch wire axis, failure to sometimes rewire the side branch, and side branch jailing. So basically 3 groups of stents have been made. One where the side branch axis is maintained, as we demonstrated today in the morning, where it's like we have access for both. It's a twin balloon technique. This is the Evantech stent, not yet available in India. And the second one is the ones where we treat the side branch, as in the capella stent, and then we go ahead and treat the main branch. This is more so used in patients where you have very large side branches. And the third one is the conical stents, the axis stent. But all these are still under evaluation. They're very short follow-up studies, and further trials and long-term required. Now, coming to the self-expandable stents, they are made out of nitinol, but still under trial. They're very early in the offing, and they're basically used in patients with bifurcation lesions, vulnerable plaques, and small vessel disease. The advantages are basically lesser edge dissections, no reflow, and lesser side branch occlusions. The disadvantages are because it is self-expandable, it has to go over a catheter, and it's bulkier and less deliverable. And the stent foreshortening is an issue, and stent expansion with larger follow-up vessel diameter is an issue because they keep expanding. Coming to the conclusions of this thing, the new generation DES will focus more on safety while preserving the efficacy. New design DES will emerge and become available. The major issue is going to be pro-healing and fast re-endothelialization rather than anti-proliferation, solving late thrombosis and restenosis. And thinner biostable polymers, bioabsorbable stents are going to be the next evolution in stents. Thank you.
Thank you, Anuj, for actually giving me a very good insight into the latest technology stents. We know we have stents as far as wire is concerned, metal section is concerned, design is concerned, and we also have with non-metal like the axis, which is the main vessel. We also have with long-term what we call stents,